This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to jerrypal.org/CME.
And on to the show. Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we got a really interesting topic today. We're going to be talking about something called late. Have you ever heard about late before?
I have not heard of late. Am I late?
Yeah, you're late to the late. Maybe you're not too late. Late and mixed dementias. How do we think about them when we're thinking about cognitive impairment? And who are our guests for this episode?
We are delighted to welcome back third-time guest Nate Chin, who is a geriatrician and medical director of the Alzheimer's Disease Research Center at the University of Wisconsin. Welcome back, Nate.
Thanks for having me.
He's also author, we should say, of a book, When Memory Fades, recently out, right? Like last month. Yep. And we'll have a link to that in our show notes. What's that about, Nate?
It is the story of my own experience with my father's early onset Alzheimer's, mixed in with what do you do when you worry about your own loved one who's having thinking changes, and then bringing in the science and the research that we'll be talking about today.
Terrific. Look forward to reading that. We hear there might be a mention of Jerry Pal in the book.
Oh, then all of our listeners,
check that out to your
book.
Listeners. Check it out. We'll have a link to that in the show notes. We're also delighted to welcome Sterling Johnson, who is a clinical neuropsychologist and dementia researcher at the University of Wisconsin, and also the principal investigator of the Clarity study of mixed dementias. Welcome, Sterling, to the Jerry Pal podcast.
Thank you, Alex. It's great to be here.
And Sterling, I think you have the song request for Alex. Is that right?
I do, Eric. I chose Blue Sky by the Allman Brothers.
Why did you choose this song?
Well, it's first of all, one of my favorite songs. Always has been for most of my adult life as a guitar hobbyist. But also it has relevance to today, to what we're talking about. Blue Sky, let's see if we can make this stretch. That's where we want to be in the diagnostic space. We want clarity to our patients. What diseases do they have? How much of Alzheimer's do they have? How much TDP-43 do they have? So we want that clarity that a Blue Sky affords. So that's why I chose that song. How is that?
That's great.
That's great.
Let's hear it, Alex.
Walk along the river, sweet lullaby. It just keeps on flowing. It don't worry about where it's going. No, no. Don't fly, Mr. Bluebird. I'm just walking down the road. Early morning sunshine tells me all I need to know. You're my blue sky, you're my sunny day. Lord, you know it makes me high when you turn your love my way. Turn your love my way.
Great song. Well done, Alex.
Yeah, fun song.
That's a tough one.
Oh, the guitar on that is amazing. People should listen to the original. It is incredible. And there's some good covers on YouTube, actually, on acoustic guitars that do justice to the solos. Yeah, amazing choice. I did not do justice, but thank you, Sterling, for that.
Thank you. That was amazing.
So, Sterling, you're the PI for the Clarity study. What is the Clarity study?
Clarity is spelled with an I at the end. It's the consortium across the ADRCs to bring clarity to diagnostics in the neurodegenerative space. So what we're trying to do in Clarity is understand which of our patients have what proteinopathy in their brain. We know Alzheimer's is, you can almost rely on that being present for our patients that come to us with memory complaints, but not always. And sometimes the things that go wrong in their brain are related to TDP-43, which we'll talk about today. Sometimes it's alpha-synuclein proteinopathy, which is commonly the culprit in Lewy Body disease and Parkinson's disease. I know we're already getting into the terminology weeds, but that's the idea of Clarity, is to bring some clarity to the diagnostic picture for our patients and to provide the tools for that.
And let me ask you this. Why did you get interested in thinking about mixed dementias and Clarity AD? Seems like there's a lot of focus on individual proteinopathies / diseases. Where'd this come for you?
I've been involved in the Wisconsin Registry for Alzheimer's Prevention and also in our ADRC for a number of years, and have been doing biomarker research in people who may be at risk for getting Alzheimer's symptoms later in life. And what we see is that some people progress a lot faster than others. Some people reach symptoms within a few years of their biomarker positivity. Some reach it after 20 or 30 years. Why all that heterogeneity? And what we have consistently heard from the pathologists who look at these brains after a person is done using them is that there is more than one pathology, and that seems to be the norm for the pathologists. When they look at the brain under the microscope, they see these other proteinopathies, this TDP proteinopathy and the alpha-synuclein proteinopathy, vascular disease. All these things can co-occur with the standard plaques and tangles that define Alzheimer's disease. And so that's what got me into it. It came from the avenue of doing a better job of diagnosing Alzheimer's and also predicting when those symptoms might happen.
There seems to be a lot of push to diagnose a particular disease. Like you have Alzheimer's disease, I think lately, because we have particular treatments for that disease. I want to hear from both of you. How much do you think that the focus on just we are going to diagnose you with a disease and pretend it's a singular disease is moving us forward or potentially setting us back? Or should we be thinking about this more as you have this syndrome, which is MCI or dementia, and then you have these collection of underlying proteinopathies that may be resulting in that? I don't know. Nate, what do you think?
Well, so, I mean, your question was, are we moving forward or backward? And I think we're moving forward.
Uh-huh.
But I also think it's because of what you just said at the second part of your question. And so we haven't lost track of the most important thing, which is the clinical presentation of our patients or our participants. We want to know their experience, and then ultimately the syndromic diagnosis of MCI or dementia. But the problem is we can't really help people unless we understand what's causing those symptoms and what's leading to further progression. And this is where it then ties back into what's underneath the surface of MCI and dementia. What are these proteinopathies, or just even below the neck? What are these other comorbid health factors that are influencing your symptoms? And so eventually we have to get to this idea of what proteins are there. And we can't get there until we know what we're looking for and we have the tools to do that. And so clarity is one way that I think we're going to be effective at this. And so Sterling's very generous in saying he works, at the ADRC and RAP. Sterling is our PI of RAP and has been an associate director of the ADRC. So he's been leading this effort and trying to just characterize what does this mean when you have memory loss? And we're pretty good at doing that from a history. And I think that's still going to be fundamental and most important. But we need to get to that next level of, okay, and now that I'm starting to understand your experience, what's the driving cause of this, or what are the multiple causes of this? And this is where we need to put biomarkers to it.
So let me ask you about that, Sterling, is that, there are some biomarkers in the last couple of years, all of a sudden became very easy to get, like in primary care. Like you can check for p-tau, other Alzheimer's, amyloid, other Alzheimer's biomarkers. And there are some that are probably the majority are very hard to get. So, are you worried at all that when we think about like the underlying causes for somebody's dementia, we're going to be focused more on which proteinopathies are easy to diagnose versus which ones are not?
Yeah, I think it is a worry. And that's what's happening now, because the tool that we have now is p-tau217, which is remarkably accurate at detecting Alzheimer's proteinopathy. It's very good. But now we need a similar success story for alpha-synuclein and TDP-43. And what we know is that pure Alzheimer's happens maybe at most 25% of the time. And that number is slightly higher for younger onsets. But for someone who's getting Alzheimer's or being diagnosed with dementia in their late 70s or 80s, the chance of them having pure disease is 25% or less.
There's
So we
no-
need these biomarkers for the other proteinopathies. We don't have them yet.
yeah. So you keep on mentioning proteinopathies rather than like when I think about mixed dementias, I think, oh, Alzheimer's, vascular, Lewy body disease, learning about late, which we'll get to. Is there a reason, or is just like use them interchangeably?
I think of those big three, Alzheimer's, Lewy body, which that's an umbrella for both Parkinson's and Lewy body dementia, and TDP-43, which is an umbrella for frontotemporal disorder, ALS, and late. All those things are TDP disorders. So those are the proteinopathies, and of course, vascular disease. That is always in play as a consideration, and is going to impact cognitive decline.
Okay. So since we've talked about late, maybe we can, because probably
I still don't know what it is.
Yeah.
I'm still waiting to hear because I'm late to the party.
What is late?
So LATE is an acronym, as we often do in medicine. Limbic-predominant, age-related, TDP-43 encephalopathy, which is, you can see now why we call it LATE.
Yeah, that's a big one.
Right. And actually, I mean, it's been studied for a while, but it really came into sort of its consensus and criteria were starting to be built a little after 2019. Neuropathologists have been looking at this and came together and said, no, we see this in brain tissue and we believe it's separate from other current brain diseases. And then more recently, Dave Wolk from University of Pennsylvania, a great behavioral neurologist, and a team of people came together with clinical criteria, did the best that they can to sort of help clinicians get a sense of what this could look like. They recognize it's far from perfect, but being able to identify this, there's no specific treatment for, but being able to potentially identify and talk to patients about it could be meaningful to them. And so now the field's really moving forward and trying to develop a way of detecting it in a living person and not just after they die.
It's really important from a clinical syndrome side of things because the TDP part of late, that's the T in late, is that it affects the hippocampus and amygdala. And so it's the same areas of the brain involved in memory that are impacted in Alzheimer's disease. And it can often mimic Alzheimer's disease symptoms.
And TDP-43 is a normal protein in our brain. Is that right?
Yeah, TDP is it's a quality control protein, lives in the nucleus of our neurons. When it diverts its way out to the cytoplasm and mislocalizes to the cytoplasm, its job as a quality control for DNA splicing, RNA splicing, it doesn't do its job as well. And so then that's when you get these TDP inclusions and clumps that build up in the neurons.
I'm glad you answered that, Sterling.
I remember we were talking with Jason Karlowish, I think it was Jason, on one of our earlier podcasts about dementia and his book. And we were talking about how, what is currently diagnosed as Alzheimer's disease is probably some heterogeneous collection. And most dementias is heterogeneous collection of dementias, some of which we haven't yet figured out. And I want to just say that, okay, this is great because now we're starting to figure out what some of these other unknowns are. Maybe. But I ran into Ken Kavinsky in the hallway and he said, well, here's the skeptical view, right? Which is that we're just not comfortable as doctors saying, I don't know what it is. So we got to find some protein that accumulates that may or may not be actually related to the disease itself. And that we can identify a protein so that we can test for it. And then we can administer a medication to treat it that may or may not be successful.
That sounds like Ken.
Yeah, right. And maybe I'm, amplifying what he said a little bit to make the point. But is there room for skepticism about is it ready to be a disease, or is this too early? Where are we on the spectrum here? And what are the forces that are driving this diagnosis?
First of all, I think what you just described is that's science. You come up with a hypothesis, you put it forward, you develop some criteria, and we see if it works. And late is sort of in that stage where we're iterating and developing as we go. And I think the clinical criteria that we have now, they're going to evolve as we get more information and get more biomarkers. But what the pathologists continue to tell us and what that literature is really evolving into is that this is something consistent. There's all kinds of neuropathologic forms of this, and there's ways that the pathologists can tell when it's present. And then now it's a matter of relating this to the various symptoms that we see.
And do you have a sense of like how deterministic is it to have these misfolded proteins in different places? Like is it like if you see it, you have cognitive impairment, or you will develop it relatively shortly? Where does that fall as far as where we are with this disease?
I think we're still getting there. How much of a protein constitutes a symptom? How much of a concentration? I don't think we know that yet.
Yeah. I mean, I think we're that's kind of the same place as we continue to learn about all of these other biomarkers. How deterministic is it? I wonder if we can then just describe what are the common symptoms that we see with late, and then
how are those different from Alzheimer's?
Yeah.
Mm-hmm.
Well, I mean, that's the key part, is that it actually looks very similar. And so this is an individual who comes in saying, I'm specifically about short-term memory. I'm feeling very forgetful. I can't recall conversations. I can't remember. I'm repeating myself. In all regards, it looks like someone with Alzheimer's disease. But what we're seeing, and now because of the advent of biomarker testing in living people can come in with those complaints, and everything that available to us is negative. They do not have Alzheimer's disease. They do not have amyloid and tau, but they're continuing to progress. So something is clearly happening, and it's at a greater trajectory than just perceived normal aging. And then they'll go to autopsy and they'll find these TDP-43 proteins. And so from a clinician standpoint, it doesn't necessarily change how we're managing things right now, but it does change conversation. And I'm sure we'll get to that later in this podcast. But in general, it's an older person over the age of 80, but I certainly think I have patients in my 70s like this, and they're going to have a very memory-specific complaint, really not that many other complaints, not language, not word finding, not executive dysfunction, and their decline is incredibly slow. And I think historically, we would look at that person and say, you must have some other genetics, or you're really resilient, good for you, but your changes are so slow. I'm very happy for you. But we wouldn't have an answer, and we still don't have an answer.
And probably before biomarkers, we would also just diagnose them with like a mild Alzheimer's disease.
Right.
Exactly.
And now you'd first check to see if they have Alzheimer's disease using some what? What would you do?
A biomarker.
Biomarker, most likely. And you would find
amyloid.
Amyloid's not elevated.
Right.
And when amyloid is... Yeah, go ahead, Nick.
Well, you can't have both, though, and that we wouldn't know that clinically in a living person. But I mean, I have a handful of cases that I keep in a separate file in my medical record of people who are amyloid negative. They have thorough cognitive testing that shows a memory-specific impairment. They're declining slowly, and I've ruled out everything else. And so I've told them, I believe this is late. And so I have these conversations in clinic.
Yeah.
Because you can't, the diagnosis itself is made in pathology after the patient has died, right? You can't.
There's no biomarker
There's no biomarker for it. But
there's no smoking gun biomarker for it right now. But what does help, there's some associated features that point us that way, like Nate said, not just memory loss, but on MRI, they'll have hippocampal atrophy, or somewhere else in the medial part of the temporal lobe. And their amyloid proteins will be kind of in the moderate range or less. If they have florid amyloid and tau signals in their brain, then that may be explaining their disease. And the conservative message there to the patient would be that Alzheimer's is driving this.
Mm-hmm. Hypothetically, in the future, if you could test for TDP-43 or the misguided version of it, is it very specific for late, or do we see it with other diseases?
That's something that our field is grappling with right now.
Yeah.
TDP is involved in 97% of ALS cases have TDP involvement, and half of the frontotemporal dementias involve TDP-43. We just don't know which half. So we really need these biomarkers.
Oh, wow.
And we don't know if it's going to be like the taus where we're going to have a specific tau marker for one tauopathy. I'm talking about Alzheimer's as a tauopathy now. You can do these. The PET scans are very specific to Alzheimer's, but they don't really light up when a person with a frontotemporal tauopathy is in the PET scanner. So we don't know if the current biomarker strategy is going to work for all these TDP variants, or if we will have to. We just don't know what it's going to look like. But there's some very good early leads on this.
And tauopathy means there's tau buildup, abnormal tau buildup in the brain.
Yeah. And so that's not TDP. That'll be taus, like Alzheimer's is a tauopathy. And the other half of the frontotemporal dementias that are not TDP, those are tauopathies, usually what we would call 4R tau or 3R tau, just different isoforms of tau. And so our PET scans that we have for Alzheimer's and our p-tau blood markers that we love so much in Alzheimer's, those don't work on the other tauopathies.
Yeah. And then who gets late? Like, how common is it in what populations?
About up to 20%, they say, of just older adults. And then it can get as high as 40% when you reach above a certain age. We think of 80, but it could be, in the 70s. So that based on those estimates, it's a good number of people will have the protein, the TDP-43 protein, but we need more, pathologic.
Is that 40% in all comers or just those with amnestic symptoms like you were describing, the memory problems? Do you know?
Certainly clarify, but I'm under the impression those are people presenting with symptoms that they're doing autopsies on and looking at.
Yeah, and it goes even higher when you look under the microscope and they have Alzheimer's proteinopathy, Alzheimer's neuropathologic change, 40 to 60%, depending on the study, it gets to be pretty high. 40 to 60% have this co-occurring TDP disease in addition to their Alzheimer's.
Uh-oh. This is really, we do need studies of mixed. Wow.
Yes, we do.
Yes.
Do they have those other pathologies too that you were mentioning, like vascular, Lewy Body?
Yeah, there's you could have all four or some mixture of those.
And then there's probably a flip side too, where if you look at autopsies of brains of people who are cognitively quite functional, normal, you probably see some of these pathologies as well, right?
We do. We see some of these pathologies, and it's really an important question. We don't know how fast these diseases progress. We know this for Alzheimer's disease. We know how many centiloid units per year that an average person would progress by, but we have no idea for these other ones. We do know that the brain is a remarkably resilient organ, and it takes a hit before, it takes quite a lot of this pathology to happen before symptoms occur.
Okay, so I can imagine, I'm just thinking in my brain, I got a couple of buckets going on in my brain. You have these older than the age of 80, they have cognitive symptoms, that's mainly memory, amyloid negative, and then you're thinking late. Is that right? Am I getting that bucket right? It's pushing us to, is there anything that we should do in that group where we're thinking this is probable late? Like, is there any drug treatment, or do any of the amyloid antibodies work, or, the Ariceps of the world, the cholinesterase inhibitors?
Well, I mean, Eric, you're a geriatrician, so we don't just jump to drugs here, but
good answer. He didn't fall into his trap.
you wouldn't think of anti-amyloid therapies because there's no amyloid there, right?
There's nothing to get rid of.
Right.
There's nothing to get rid of. I think it's more of this counseling conversation with the patient who already has, in this situation, they would have MCI or dementia anyways. They're going to be focusing on the symptoms. They don't care about the terminology per se. They want, what can you do to help me? And that's where we talk about our our lifestyle. That's where we talk about routines and structure and support and all the things that we know are meaningful and helpful for both the patient and their family. However, the family might be very interested to know if this is truly late and not some form of Alzheimer's, because there's, when people have Alzheimer's disease, they think of their own inheritance and what that looks like. And so, but I also think it's counseling on if it truly is late, this is probably going to be slow. We don't hear about rapidly progressive late, at least not now. And so I think people can feel a sense of reassurance, at least some of my patients have, in not only validating.
Like how
that
slow? Does it eventually turn into like more advanced dementia, or is it just like a very slow?
Oh no, I mean, it progresses.
Yeah.
I mean,
It progresses.
and frankly, other things could happen too. So you could
Sure.
have a stroke, could develop Alzheimer's during the interim. But the people that I think I'm treating that have late, it truly is incredibly slow. And people are just really appreciative. And I think people like knowing, oh, okay, it might be this new thing that we're thinking about. And that would explain why we're not seeing, quote, the typical case of decline. And I
Yeah.
think in that regard, there's personal utility to families and patients hearing this. And to Ken's point, it's okay to say, I don't know. I know it's not Alzheimer's based on this, but it could be this. And my patients have been very content hearing the I don't know, but it could be.
Do you ever use, I'm going to go back to the farm part. Like, do you ever use memantine or Aricept in this population?
Yes, because I think of those drugs as non-specific and palliative. And I will make that case over and over again.
Yeah.
That if it's really just about quality of life and symptoms, and these medications were to reduce the frequency or severity of symptoms, then yes, I think that could be meaningful to some for a short period of time, but it takes time to have that shared decision-making conversation, but yes.
And I guess, Sterling, if we actually thought about this from an evidence-based standpoint, from the original cholinesterase inhibitors, memantine trials, we actually don't have biomarkers from there. So it probably was a mixed bag of patients with Alzheimer's type dementia that they were studying. Is that right?
Oh yeah, we were so hobbled back in those early days. We had no idea. I think that really explains the lack of treatments over those 20 years before lecanemab and donanemab got approved. Yeah, we were flying blind in a lot of cases.
Do you think if there was a drug that cleared TDP-43 like it clears amyloid, that it would work, or we just absolutely just don't know?
That's the $1 million question. We need to get to that place. We need to identify targets, these drug targets, and try these things out. But before we do, we need to know who's got it. And that's the catch-22 that we're in.
Yeah.
We don't have a biomarker to tell us who's got it.
So on average, I'm hearing that late progresses more slowly than Alzheimer's disease progresses. That while
Correct.
Alzheimer's disease can progress slowly, on average, Alzheimer's disease progresses faster than late.
That's right.
Yeah. And that patients may have a much longer life expectancy with late than they do with Alzheimer's disease, to put it another way.
That seems like a fair statement.
Yeah. And
Okay.
they may be more likely to die with late than of late, potentially. Maybe. Given that it's so common in advanced stages and people have other conditions in advanced stages.
So that feels like the easy bucket for me, these people who are amyloid negative. But if they're amyloid positive, if it really is that common just in people who are amyloid negative, I'm assuming it's just as common in people who are amyloid positive. So that probably means that a lot of people who were also saying have quote unquote Alzheimer's disease, maybe we should put those in parentheses from now on, have all of these underlying other proteinopathies. Is that fair?
I think so. And when those are present, then we don't have, late is typically thought of as this indolent, slow progressor. But if it's co-occurring with Lewy body or co-occurring with Alzheimer's, then that progression rate is going to be a lot faster.
Is
we
it
don't know fast, but it seems to be a lot faster from the
Is it faster than just late itself, or is it faster than just having Alzheimer's by itself?
It's faster than having Alzheimer's by itself.
Oh, so the combination now. Oh, do we see that with other mixed dementias like vascular and Alzheimer's disease?
do.
And so the combination of these multiple insults increasing the speed of the disease progression.
That's right. When you have Alzheimer's plus vascular, your progression is going to be faster. If you have Alzheimer's plus alpha-synuclein, your progression is going to be faster.
Mm-hmm.
Okay. So we have this bucket now where they're amyloid positive, but we can't rule out late. So do we know anything about like how, let's say, that amyloid antibodies work in this population, or we also don't know?
I mean, we don't know that either for Lewy body disease, and
Vascular disease.
and to some degree, vascular. I mean, we have
Well, I
some
guess-
better.
Right.
Right?
It was a more pure population enrolled in
Yeah.
these studies, right?
Well, I just think it speaks to this fact that when we tell someone, okay, you have mild cognitive impairment, Alzheimer's disease is the most likely cause. There has to be this space of, but there could be other things too that we have yet to be able to detect that we don't know even exist, because the brain is still sort of this, it's this last frontier of our true understanding. And so if we leave that door open to, there are lots of things that could be happening. We believe in this alpha-synuclein, we believe in these other proteins. We just can't detect them. They could be present, may not be, but we're leaving that possibility.
Yeah.
A lot of what we know about the longitudinal nature of late and its amplifying effect on Alzheimer's, if they happen to have both, a lot of this has come from the knowledge that we've gotten from the Alzheimer's centers, where you've got a group of very generous patients who donate their brain. We look at their brain, but they also have had maybe 10, 15 years of observations when they were alive and participating in the center program, and they would get their cognition measured every year. So we can take the information from the actual brain, from the microscope, the late diagnosis, the Alzheimer's diagnosis, and then work backward. And a lot of this has come from that kind of experimental design. It's not ideal, but it's not a biomarker. That's what we've gotten so far.
Can I ask you from a generalizability standpoint? So historically, a lot of these memory centers were wealthy and white and well-educated. I guess those 3 W's. Is that changing? And how generalizable are these studies, even around late, to a more diverse audience or a more diverse population?
I would just maybe just offer our experience with clarity with an I at the end. When we approached the Alzheimer's centers and we said, is this something you want to do? And what do you think is going to be important? All the directors, almost to a T, would say, we want this study to be diverse. We want it to be generalizable. And in Clarity, we're about to enroll our 1,000th participant this month. 50% of our participants are from a diverse group.
Wow.
36% are from these race and ethnicity defined subgroups. And then we've got we're looking at education levels as well as how rural their zip code is. And we're looking at all those things, but 50% are...
Broad view of diversity too.
Yeah.
I think what Sterling's pointing to is really important. Every center is going to have their own limitation based on the population that surrounds them. I think a lot of centers still struggle with this idea of rural versus urban or just geographically.
Yeah.
There are 35, 36 centers across the country, each focused on something different. And so whereas Wisconsin might be, we have great participation, we're having increasing participation with rural, African-American, Native American, but others might be focused on Latino in California. They might be focused on East Asian. So when you look at all of them together, and NAC, which is the National Alzheimer's Coordinating Center, which really collects all of the data from these centers, there's over 10,000 human beings who are, collectively representing more of a diverse sample. So when you analyze that as a whole, then you start getting better representation. It's still not perfect. I don't think anyone thinks it is, but it's improving. And so I think they're starting to have, when we say these things of like, this is what we're seeing, it is starting to feel more generalizable than one single center or one single study.
So I'm going to ask another increasingly controversial question. So let's say you look at the donanemab study published in JAMA, I think, excluded people older than the age of 85. Lecanemab excluded people over the age of 90, but there were few people who were a lot older in that study. Given that late is very common in those who are older than 80, how generalizable do you think those studies are, given that there's an increased mixed picture as you get older for cognitive impairment dementia?
I mean, I think that's a limitation of these trials. Whenever you have a cutoff or you just don't have enough
Do you bring it up with patients now?
adults. What's that?
Do you bring it up with patients? Like, we don't know?
Sure.
Yeah?
I bring it up with my patients of color as well, that this is what the study showed, but there weren't many people that looked exactly like you. They didn't look exactly like me. Does that really deter their willingness if they're already interested? In most cases, no. I think it really does motivate people to join research to get that representation.
Yeah.
But I think, and you guys see this too in your clinics, when you have for years not had anything to offer people that would modify the biology and the course of disease, and then you do have these trials that were done as they were supposed to be done and show even a modest benefit, I think people are willing to say, okay, this is imperfect science. We need to do better in better representation. But based on what I'm seeing, okay, I'm going to make this decision one way or the other.
Do most agree to take the drug in your experience?
No.
Or? No.
Not in my clinic. And certainly I have a lot of older patients as a geriatrician, and many of them will say to me, I feel like I'm doing pretty well, and I'm not wanting to address the hassle factor of going to the infusion center or address the risks that you talk about. But let's keep me posted on what's happening in the field. And so, no, the majority of mine are not. There's still a good percentage in our program that do. And I think they feel good about these decisions, probably because we spend so much time going over this discussion.
And Sterling, I'm going to ask you the same question, especially coming from a mixed dementia standpoint. How pure Alzheimer's do you think that sample was that they studied in lecanemab and donanemab versus there's still probably a lot of mixed dementias going on, and that probably maybe is contributing to the fact that it didn't work as well as
it removed a lot of amyloid,
but people still continued to progress. Like, where do you think it falls in that spectrum?
Oh, yeah, it did hobble the clinical outcome. There was a 26% reduction in lecanemab and 35% in donanemab. And if those had been pure cases, I bet those, the percent reduction rate of change on the clinical dementia rating scale would have been more pronounced. What we just saw last week in London, there was a new tau phase 2 that Biogen presented, and they did take the time to measure copathology. They took spinal fluid and they did the seed amplification test for alpha-synuclein. The only reasonably good marker for Lewy Body proteinopathy that we have. It's CSF. But they did that in their study, and they found that 30% of people had synuclein in their supposedly very clean study of Alzheimer's disease. And so it's going to be present. We just have to we got to be clever enough with our experimental designs to just know that it's going to be there. And just the pharma companies are starting to do that now.
So my probably last controversial question.
And then I got one that's less controversial.
Given that we are I don't know, I just did a PubMed search for late. The first time it came up, it was 2019 as far as the full title for late, which I'm not going to repeat because I won't remember. Like, we are in a phase, we were learning so much, and we're learning so much that there may be these underlying proteinopathies that it may be more confusing than just the single one. How important is it that there's two camps, it seems like right now. One camp, you have saying that we are going to diagnose Alzheimer's just based on tau and amyloid proteinopathy. And then you have Alzheimer's disease if you're positive. Versus another camp is, no, the science isn't quite there yet. We're still going to call this a clinical pathological construct. And maybe just call it a proteinopathy instead. Like, they have this amyloidopathy that may be resulting in their cognitive impairment. Where do you fall in those camps? Nate? All right, Sterling?
Yeah, I'll start. Nate's the sage one here. He's got better, more circumspect advice than me, but I am very much of the camp where we have to get more precise as in our constructs. And so I would be in favor of splitting these into the various proteinopathies that are there. That's how we're going to treat these things.
Yeah.
What do you think, Nate?
I mean, we're from the same institution and we conduct research together. But Eric knows my answer because he and I talk about this frequently and via emails.
I'm going to be at Nate's podcasts. We're recording tomorrow. Dementia Matters. Go check it out.
That's right. And we're going to talk about the importance of assessing, clinical symptoms and function. But I still believe biology is biology. And we define Alzheimer's disease as the presence of elevated amyloid and tau neuropathologically. We can identify that in living people. Just because they don't have symptoms does not mean that biology is not there. I think we have to separate the science from the human experience. And of course, we care the most about the human experience.
Yeah.
But by understanding the science and intervening with the science, we can improve that human experience. So I'm very comfortable with this concept of preclinical or asymptomatic, pre-symptomatic. And I say that to my patients too. I just think that we have to disentangle that part of it.
Yeah.
And I completely understand the people who are wanting to combine it because I love the fact that they care the most about the person. But I do think we help the person the most, especially the future, when we start looking just at the biology too, separate from symptoms.
Yeah. And why not both? Tune into Dementia Matters, hosted by Nate Chin.
Read When Memory Fades, also by Nate Chen. And look for the results of the Clarity with an Eye study. Last question from me before we go. What is your blue sky here? Like, if you cast your mind into the future, I'm sure if you cast your mind like 200 years into the future, to be sure we'll have cured all these things, we'll have figured it out. But let's talk something more in immediate future, like 5-10 years. What's the blue sky of where we are at that time point in terms of like the dementia diagnosis and treatment landscape?
I'm going to go with 10 years to be a little bit safer. And I'm going to say my blue sky is being able to identify the multiple different things that we believe are happening in the brain so early that we can then have multimodal therapies to intervene there and therefore prevent the onset of symptoms and or just delay progression of symptoms so that people die of something else besides a neurodegenerative disease. I would love for people to not have to go through that end stage of dementia and instead have something else like other Americans where it's cardiovascular or cancer or something else.
Well said. I agree completely with Nate.
Mm-hmm. Great. How about we get a little bit more blue sky then?
Don't fly, Mr. Bluebird, I'm just walking down the road. Early morning sunshine, tell me all I need to know. You're my blue sky, you're my sunny day. Lord, you know it makes me high when you turn your love my way. Turn your love my way.
That was great. It's a good song.
Yeah, it's a jam. I wish I could do all the little licks. Sterling can probably do the licks.
Next time,
Sterling
can you do the
will play
licks?
the song.
I used to be able to do it, but
Yeah.
that was great.
Sterling,
That was
Nate,
great.
thanks
I
for
think
joining us.
Yeah, happy to do it. Hopefully there's something in there that's useful.
Oh, that was fabulous. And thank you to listeners for your continued support. We'd also like to do a big shout out to those who've donated more than $250 in the last year, including
Carrie Levy, Marnie Feltzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rock, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulsky and Yana Saraf, Kelly Strait, Michael Bordowski, Jessica McFarland, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, the John A. Hartford Foundation, Lloyd Woolstat, Harry Hahn, Bob Arnold, Ginger Robbins, Matt Schuster, Maureen Kearney, and Kenny Lamb.
Thank you.